All right, so we're going to talk about Chapter 4, Communications and Documentation. In this, we're going to learn about like repeater systems and how radios work with communications that way, and then really just how to document a good narrative, as you guys will be required to write a narrative for every patient contact you have for the required contacts needed. All right, so going through the same thing, standard competencies. Therapeutic communication, principles of communicating with patients in a manner that achieves a positive relationship. So interviewing techniques we're going to go over. I like to call it interrogation in a roundabout way, because really we're interrogating a patient to get information out of them, but really it's interviewing to kind of see how we can get certain things. I'll teach you guys how to ask certain questions to get the right answers you're looking for. Adjusting communication strategies for age, stage of development, patients with special needs, and differing cultures. Verbal diffusing strategies, family presence issues, also EMS system communications on communication needed to call for resources, transfer care of a patient, interact within the team structure, EMS communication system, communication with other healthcare professionals, and team communication and dynamics. And then documentation, recording patient findings, and then principles of medical documentation and report writing. So medical terminology as well. So it uses foundational, anatomical, and medical terms and abbreviations in written and oral communication with colleagues and other healthcare professionals. So communication is the transmission of information to another person, whether it be verbal or non-verbal through body language. Verbal communication skills are important for EMTs. So enable you to gather critical information, coordinate with other responders, interact with other healthcare professionals. So we have to be very good at verbalizing stuff and having a conversation. So if you're a shy person that doesn't like to talk, we have to break that and get into a point where you feel comfortable talking in front of crowds. Because you may have to make important decisions and ask the important questions in front of multiple people at one time. So to have stage fright, we got to kind of break through that. And by doing so, we'll work with you during our practical sessions that we have to kind of help with that moving forward. Documentation is a patient's permanent medical record. And when I say permanent medical record, it stays with them from when you drop off the patient at the ER and complete your run report. There are, if they go to like the intensive care unit or med surg, surgery or whatever, these physicians are reading our run reports from pre-hospital care, so they have an idea of what actually happened initially when we first got there. So this stays with the permanent medical record. And even if the patient gets transferred from a critical access hospital and gets transferred, let's say, Maine Medical Center, Dartmouth, Portsmouth, the bigger level 1, level 2 trauma centers, our run report actually goes with that chart with the patient, so the physicians down there can actually see what happened. It also demonstrates appropriate care was delivered, because remember, if it wasn't documented, it didn't happen. So again, you have to make sure you document everything. It also helps others in patients' future care. Complete patient records as well, guarantee proper transfer of responsibility. Comply with requirements of health departments and law enforcement agencies, and fulfills your organization's administrative needs. And what they mean by that also is billing aspect of it, because without that, we can't bill for anything. Radio and telephone communications, link the EMT to EMS, fire department, and law enforcement. And you must know what your system can and cannot do, and how to use the system efficiently and effectively. Therapeutic communication uses various communication techniques and strategies, both verbal and nonverbal. Encourages patients to express how they feel and achieves a positive relationship with each patient. So what we're saying here is we got to actually get down to their level. Show that we actually care about these patients. Whether we choose to want to care about them or not, we have to care. So if we're dealing like with the elderly, so for me, I'm 6'4". So when I walk up to a patient who's 5'6", and I'm towering over them, I'm going to scare the hell out of them, right? And that's not what we want here. We want to make sure they can trust us as we walk through the door and be able to give the answers without being frightened by doing so. So I'm going to get down to my knees or down to a lower level and become eye level with them, communicating, and that's more of your nonverbal stuff. Be able to show that you care, get down to their level, have a conversation with them to be able to get the information you're looking for. And pediatrics or kids is another whole different story, because when we're dealing with them, they get very afraid of adults and people they don't know approaching them. So what we talk about later on is the head to toe assessment. We're going to do a pediatric assessment from toe to head and kind of gain their trust by grabbing their feet and assessing their feet and working our way up to their head. Now, obviously, ABCs come first, but if they're crying, if they're talking, we know they have an open patent airway. We know they're breathing okay. We can start from an assessment, working our way from down to up. Also, by getting on the same level as them, having an understanding and being empathetic to them, it also encourages the patient to express how they truly do feel. And that's what we need to know, is how they feel. The Shannon-Weaver communication model is the sender takes a thought and codes it into a message. At that point, they then send the message to the receiver. The receiver decodes the message and sends feedback to the sender. So that's how that's working, as you can see here. So some factors and strategies to consider during communication are age, body language, clothing, culture, education, environment, eye contact, facial expression, gender, posture, voice tempo, and volume. So some different factors to look into. Now, keep in mind, if they're kids, all right, and let's say they're a 5-year-old, I'm not going to walk up and say, "Gee, do you mind if I assess your abdomen?" Just say, "I'm going to put my hands on your belly." You can change some of those terminologies to work towards the specific age you're dealing with. Another hard thing to do also is dealing with kids with like Down syndrome or different special challenges, is because to actually approach them, some of them may not like even being touched at all. So you've got to kind of gain their confidence. Another thing you can do too is have family kind of do that as well. You can have mom or dad like palpate the stomach, let me know how it feels. Things like that where they might feel more comfortable. You use the resources that you have around you to kind of help with that. Looking at facial expressions. If I'm palpating an abdomen and there's, oh, it doesn't hurt, but they're wincing in pain, I can now say that they're actually in pain. And things like that. Look at their body language as well. How are they looking to you? You can definitely tell with people that don't like making eye contact. Sometimes they may not be telling the truth. So a lot of this you might see in abdominal pain, 16-year-old female who you ask, "Are you sexually active?" You think that they're going to want to be honest in front of their parents. So the eye contact may be a little different. You can kind of sense that maybe they're not giving you the truth at this point in time, and try to find a way to separate parent from child so you can actually have that conversation. Are they sexually active? Is there any chance they could be pregnant? Things like that. Because I tell you right now, there might be some 14 or 15-year-olds that are sexually active that don't want their parents to know they could be pregnant right now. So there's some things to consider. Shape how a person communicates. If you walk in being that a-hole, they're probably going to be one back to you. Again, so you got to kind of shape how you want this person to communicate. Walk in there, show that you care, show that you're empathetic, show that you're sympathetic, and as you're walking in, they may give you back the same respect. All right. Body language and eye contact are greatly affected by the culture as well, by cultures. And in some cultures, direct eye contact is impolite. Again, I don't know every culture that's out there and how they're supposed to work, but they may tell you, hey, it's impolite to have direct eye contact with me. In some cultures, it's also impolite to look away while speaking as well. Tone, pace, and volume of language. reflect the mood of the person and perceived importance of the message. So some things to think about as you're approaching your patient and talking with them is how they perceive you speaking to them. So if I walk in, I start yelling at them, do you have any chest pain? My voice may come across as being aggressive, and then you're like, why are you yelling at me? Well, you're old, so I kind of figured you were hard of hearing. That's not necessarily the case. So I always go in with a positive attitude with them. I speak at a normal level. I speak slow enough so they can understand what I'm saying, but not too slow that they start thinking that I'm thinking they're challenged of some way. And if they say to me, can you please speak up? I have a hard time hearing, then I'll raise my volume. They may say you're going too fast. They may say you're going too slow. Then you can adjust your assessment from there. Don't consider your own cultural values more important than those of others. All right. And also forcing your values on others as well. We don't do that in the back of an ambulance or with a patient. You may be a believer in God, a believer in church, but it is not your place to start putting that on somebody else in the back of an ambulance, saying that you need to convert to Christianity or something like that. That is not what we do. Our job is to come in, treat a patient medically, and get them to the hospital. So forcing your values and beliefs onto somebody else can actually cause a lot more hate and discontent. Nonverbal communication for body language provides more information than words alone. Even without exchanging any words, you should be able to tell the mood of your patient. If they're standing there with their one leg back, their fists are clenched, their arms look tense, what does that say to you guys? Angry, frustrated. Are these the patients that you want to come up close to and start doing an assessment?
No.
So we got to find a way to de-escalate that to the point where they actually let you come in, but still look at body language, because people that are schizophrenic, right, and they start hearing voices in their head, they may say, oh, he's okay, let him in. And the next thing you know, attack, hurt him. So you got to kind of keep your distance away, but also never lose sight of the body language that's there. Facial expressions, body language, and eye contact are a powerful communication tool. Dealing with psych patients alone, it's very difficult because psych patients want to be manipulative at times too, and they want to try to convince you there's nothing wrong, even though there actually is. So some things you may have problems with in dealing with this is never let them get the upper hand on you. Make sure you always have the upper hand, and make sure that things are always in your control. So once you've taken away that eye contact and you've shown that they are more powerful than you, they may take that advantage to come after you and manipulate you and or physically hurt you. So you've got to keep the one up on them, but also still remain professional and calm. Does that make sense?
Yes.
Okay.
Yes, it does.
Perfect.
Yeah.
And Kim, I'm sure you can probably elaborate a little bit more on this as well in your profession of dealing with these people. You don't ever want to let them get the upper hand on you.
No, because it's considered a weakness, and typically when that happens, you're going to be dealing with the same person over and over, and they're going to manipulate you over and over. Exactly. And you get ahead.
Yep. So that's why you always want to make sure you have the upper hand and you're in control of the situation. But once you've lost control of it, they've now owned you, and that's what we don't want. When we get into behavioral emergencies, we'll start showing you guys different things on that point when we get to that point there. While treating a potentially hostile patient, be aware of your own body language as well. The last thing that you want is to show that you're going to become a threat to them. So by you clenching your fist like you're going to hit somebody, probably not the best thing to do. Still remain calm for as long as you possibly can. And again, if you feel like you're in a bad situation, leave. Just say, I'm out. See ya. And walk backwards away from them until you get to the point where you can turn and run. All right?
And another thing, sorry, my dog is being obnoxious, but for the females in this group, I know not everybody can be confident with like a hostile male that's being aggressive or anything. And if you, correct me if I'm wrong, if you feel that you can't handle that certain situation or calm them down or anything, don't feel ashamed in yourself and asking for help for like with a bigger male or something to assist you with calming the guy down.
No, you're right. Don't go into a situation that you can't keep control of. And if you need more manpower, law enforcement. The one thing I like about having law enforcement with me is they have the power to arrest and take people down, and they also have guns and tasers, so things that we don't carry on EMS, at least not in this service that I work for. So that's the thing. Another thing too, though, is again, is size also plays a big factor as well. I got somebody who's let's say a male 5'6", and I walk in at 6'4", 300 pounds, walking into a room. Could they feel threatened? Especially if they're psych.
Mm-hmm.
So that's another thing too. You got to you can't walk in there with an aggressive nature, because they may in turn say, he's aggressive, I'm going to be aggressive, and this could turn into something way worse than what it needs to be. So always stay calm and try to diffuse the situation. And the best thing you can do is try to talk them. So assess the safety of the scene first, and do not assume any kind of aggressive posture. Make good eye contact, but do not stare at them, because they can take that as a threat. Speak calmly, confident, and slowly. Let them know what's going on. Hey, we're here with EMS. We really want to help you out. What's going on today? They start talking to you. Say, oh, I understand what you're going through. And say, what can we do to help you right now? Let them come up with some things. Let them play part of that. And eventually say, hey, do you mind if we go sit down together? Do you mind if we, just talk? I don't even have to get an assessment at this point in time yet, as far as like vital signs and heart rate and all that, because he's standing there in front of me. He's alert and oriented because he's talking to me. He has an open airway. He's breathing. He's not bleeding out, so his circulation is good. He's not pale. He's pink, warm, and dry. These are all things I've done on an assessment without even having to touch the patient. Do I have time to sit there and talk with him? Yes. Try to get them to sit down. Again, always keep yourself between you and the exit so you can get out if need be. But try to de-escalate that by diffusing the situation, getting him to that point. Never threaten the patient either verbally or physically. If you don't get on the stretcher, I'm going to throw you on your, you don't get into that kind of stuff. The best thing to do is have them come out on their own free will and go to the hospital. But again, there's going to be times in your career where they're going to tell you no, and they're going to have to go, and they're going to be physically and verbally abusive. I have probably been called anything you can probably think of. I've been called on a scene or in the back of an ambulance. I'm sure most of you have seen this already or had this happen to you. Don't let it get to you. All right? Because once they know it's getting to you, then at that point in time, they're going to keep attacking that. Because like Kim said, you have a weakness they found, and that weakness they're going to attack to the point where you start breaking. All right? So that's what we don't want. So in that case, let them verbally assault you. You know what? You already know who you are. You already know you're better than that. Just work with it. Do your best. Be positive. If after the call is done, you need to go out and vent, scream somewhere, whatever, after the call is completed, then go ahead and do that. But calm, cool, collective, and get through your call. Some physical factors, obviously, literal noise, sounds in the environment, lighting, distance, or physical obstacles may affect your communication. Don't put yourself in a dark room. Even if the scene is safe for what your knowledge is, again, there could be needles on the ground. There could be anything that you don't know. There could be whatever, anything that you could be walking into. You have no idea what you're coming into. Make sure you have good, adequate lighting. If you don't, make sure you have enough flashlights with you to be able to see where you're going. Cultural norms often dictate the amount of space or proximity between people and communicating. Now, what's the norm now? Well, let's stand back 6 feet, right? So that's kind of a new norm now when we walk into places and around here because of the whole COVID-19. Gestures, body movements, and attitude towards the patient are critically important. If I approach a patient at a fast pace, what are they going to think? They're going to think I'm here to attack them or hurt them. So I come in at a slow pace, let them know what's going on, and I'm always communicating with somebody. Asking questions is a fundamental aspect of pre-hospital care. Again, open-ended questions require some level of detail. So whenever possible, use whenever possible, like what seems to be bothering you. So another thing with verbal communication as well is when I'm asking a patient something, especially the elderly, the last thing I want to do is do this. Ma'am, do you have any chest pain? Do you have any shortness of breath? Do you have any dizziness? Any nausea? And she says yes. What was her answer yes to? Was it all four of them? One of the four? Two of the four? So ask one question at a time. Leave it open-ended for them to give you an answer. Ma'am, do you have any chest pain? If she says yes, what kind of chest pain is it? Does it radiate anywhere? She says, no, it stays right in my chest. What does it feel like? Is it sharp, dull, or pressure? Well, it feels like a pressure, like something sitting on my chest. And she has more time to actually come back with good answers. And everything I just went over with you guys right now is actually very important. That's all important information to know when assessing this, because if it's a pressure-like pain in her chest, let's say it is radiating, could that be presumed a cardiac condition? Absolutely, it could. Versus a sharp pain in the chest when she was just outside mowing the lawn or lifting something. Could that be pleuritic pain versus, reproducible versus non-reproducible? So there's a lot of things when we get into cardiac assessment that you're going to see this in. But again, open-ended questions, wait for them to give you an answer, and don't pile too many questions onto somebody, because that becomes very confusing, especially when they're elderly and things have to be done at a slower pace. Closed-ended questions can be answered in a very short response. These are more of your yes or no. Are you having any trouble breathing? Yes or no. Response is sometimes a single word, used if patients cannot provide long answers. I use both in my assessment. I like open-ended questions. I like closed-ended questions because I can say, how are you feeling today? Let me know. Now, they start talking about how they had knee pain 6 weeks ago. I'm going to stop them and kind of redirect them without being rude into the path I want to go down for an assessment. And then I can start throwing in my closed-ended questions about chest pain, shortness of breath, dizziness, nausea, blurry vision, headache, vomiting, diarrhea, all the other stuff I need to know. I can throw all that into in the closed-ended questions, and I can take that information, formulate a plan of what's wrong with them, come up with a diagnosis that I want to follow, and start a treatment plan. And this usually occurs in a matter of about 3 to 4 minutes, and we have a decision to make. Other communication tools is facilitation, silence, reflection, empathy, clarification, summary, explanation, interpretation, and confrontation. All right, so these are all different communication tools that are out there that we can utilize. Interviewing techniques is also very important as well, because when interviewing a patient, consider using a touch to show caring and compassion. So do you see the picture over here? How she has her hand on his in his hand on the shoulder. Is that showing that she has compassion?
Yes.
Absolutely, it is. But at the same time, though, if you slipped your hand up the wrist a little bit more and put your fingers over his radial pulse, not only am I showing compassion, but I'm also doing an assessment at the same time. You can kind of play those two together. It's kind of like when you're assessing a respiratory rate but feeling for abdominal pain. By putting your hand on their stomach, you can actually see the rise and fall, and you can actually count respiratory rates as well as also assessing. It also shows with a soft touch that you actually care. But again, no touching of the patient until they give you consent to do so. Avoid touching the torso, the chest, and face. Right? Face touching is not good unless you're doing a true assessment of the face for trauma. The chest assessments, trauma patients, absolutely. Medical patients, if they have chest pain, a push on the sternum. Keep in mind of breasts on females. Okay, again, it's our job to assess, but we're not doing breast exams. So again, you got to be careful where you place your hands. There's certain techniques I'll show you guys during practical stations of how to assess a female chest without having to get too personal. Things to avoid: providing false assurance or reassurance. Everything's going to be okay. Oh, your injuries aren't that bad, even though their legs hanging off by a thread. Giving unsolicited advice, asking or leading or biased questions. talking too much. Way too much talk is bad. Get to the point, get your information out, find out what you need to know. If a patient's talking to you, don't interrupt them. But if they're going down a path where you don't want to go, like you don't need to know about how they had, gallbladder removed 40 years ago, well, that might be important depending on chest pain and burning, but that's probably a bad example. That they had a hangnail removed 3 weeks ago. If we're going down that route, I kind of want to control the questioning and their responses and kind of tailor it to where I want to go, so I can kind of direct them into that way. Using why questions. Why questions give you way too much information that you don't need to know. Using authoritative language. You're going to give me this information. And speaking in professional jargon. The last thing you want is to walk to a layperson who knows nothing about medical terminology and start throwing out different things like, for example, zygomatic bone. Why don't I just say, does your cheekbone hurt? You know what I mean? Calf muscles, or I could say gastrocnemius muscle, right? They're not going to have any idea what you're talking about using big medical words. And they're like, what are you talking about? Does your calf hurt today? You have calf pain? You can say abdomen to the adults. People know what the abdomen is. Kids may not know what an abdomen is. They may know it as stomach or belly. I'm going to start palpating your intercostal muscles on your chest. So try to get away from the professional jargon that we use and go into kind of their terminology of the layperson. Now, when you're documenting in your run report, you can use all the medical terminology, professional jargon you want. Keep it out of the assessment itself, though. Does that make sense? All right.
Yes.
Yes.
Okay.
Yes.
So friends and family may be valuable during the patient interview process because they may also have a lot of information, especially when they're pediatrics or if they're dementia or if they have any kind of Alzheimer's where they may not know what's going on, or even if it's a psych patient, family may have more of an insight of the psychiatric history that's going on here. Allow the patient to answer, even if well-meaning family members attempt to answer for the individual. Do not be afraid to ask others to step aside for a moment. There's times when I've been interviewing a patient to find out information, and the wife or the husband answer all the questions. I say, sir or ma'am, I need to hear this information from him because I'm actually assessing them right now. If I have any questions, I will come to you and let you know. So they're like, oh, okay. They understand that. Because by me asking questions, even though I already know the answers from the family, I'm actually assessing their mental status to see how they're doing. So golden rules. So make and keep eye contact at all times. I know sometimes you might not have to, but always have eye contact of some sort with the body because you never know what's going to happen. Also, it shows respect. The one thing I've noticed about the elderly, okay, if you don't make eye contact, you're not respecting them. It's one thing that I've always noticed. Get down to their level. What I mean by level is same level, eye to eye contact, not above or below them, but right the same level, and have a conversation. And sometimes they may have called 911 because they just want to talk to somebody. And there's nothing wrong with doing what they call PFA, which is psychological first aid. Provide your name and use the patient's proper name. Mr., Mrs. So Mrs. Smith, well, call me Jane. Okay, I will call you Jane because she gave me permission to call her by her first name. Be proper with that. I never give my full name to anybody, and I hate the fact they put our names on uniforms and ID tags because I don't want people to know who I am. But I'll address it as my first name. I never give out my last name. I always say, my name is Kevin. I'm here with the ambulance. I'm here to help you. Tell the patient the truth. Don't ever lie to a patient. If they catch you in a lie, you've now lost them. They're gone, especially with psych patients as well. Use language the patient can understand. Be careful what you say about the patient to others. And be aware of your body language as well. It also means good.
I just have a question about the name thing. So
Like, I'm similar to you in that I don't always want to give my name out to everybody. Can we give like a nickname or something?
I guess you can if you want to. I never had a problem with me giving out my first name before. But if you want to use a nickname, that's perfectly fine too. Just make sure your partner knows that when you're doing it. But if your name is Paul, don't say your name is Jim. Right?
Right.
You don't want to lie about that.
No, I go by my initials. K-A-Y. Pretty simple.
That's fine.
I'm not sure how it is in the private sector, but working, for a municipality, if somebody asks you your name, you have to give them, your first and last name, if that's what they request. Now, on a private service, I'm not sure how that works.
Yeah. So in the private sector, our uniforms, like we have polo shirts that we wear, and it has my first name, last initial.
Right.
But my ID badge has my full name on it. So I've had instances in other services that I worked for where the patient got the name. I'm going back to the alphanumeric pager days though, if they even still exist very much anymore.
Wow.
And I was working for Northeast Ambulance. I'm going back to like 2001, 2002. So I'm going back quite a few years. And this kind of sticks in my head because a good friend of mine, we were partners, and we did a transfer of a psychiatric patient, and he had his name tag on. He saw the full name. So she got out of there, out of the psychiatric facility. She called Northeast Ambulance, asked for the provider's name. I'm sorry, she had the provider's name and said, "Hey, can you get in touch with him, please? I'd like to speak with him." So they gave him the pager number. Big mistake on the management part, giving out his pager number. She pages him. He answers the phone, or calls her back, I should say, based on the pager number, and she's asking him out on a date. He's like, "Whoa, wait a minute, who are you?" And then he went and remembered the patient's name and goes, "Holy crap, I just transferred, didn't tell her this, but I transported you for psychiatric to a hospital, to a psych facility." And then she stalked him for
Some
months.
creepy stuff.
So again, this is why I don't like giving out a full name, because then they can call. But management never should have given out the number anyways. So they got some trouble with that. But still, they can look things up now with the power of Google, Facebook, and everything else.
Yeah, Kevin, I was going to say, I know people that have been looked up on Facebook and stuff.
Yep. And it happens. Anybody that applies, that wants to apply for Action Ambulance where I work, because I'm part of the employment process of hiring and orientation, I look you guys up to see who you are. I want to see what kind of people you are. But I also have your name given to me. It's different when you're a psych patient and your name is given out. You know what I mean?
See, and our polo shirts have our last name on them.
Right. And I don't like that because your name's now given out. But again, it's your company policy, it's whatever it may be. So that's totally up to your organization. But again, though, I always like to give first name out first, and that's all I give them. But again, they see my ID badge, so they already know who I am anyways. So another thing would be to speak slowly, clearly, and distinctly. So if I say to you, again, I'll go with the chest pain thing. Man, do you have any chest pain, shortness of breath, dizziness, nausea, vomiting, diarrhea, headache, blurry vision? They're like, what just happened? So I want to enunciate things a little bit better. Ma'am, do you have any chest pain? Ma'am, do you have any shortness of breath? Are you dizzy at all? Does you feel like the room is spinning? Slowly, clearly give the information out, and it'll be easier for them to give you answers you're looking for. If the patient is hard of hearing, face the patient so he or she can read your lips. A lot of times that's what happens. So if you're a mumbler, it may be hard for them to actually look at your lips and see what you're saying. And if you're going too fast, they're going to become confused. Allow the patient time to answer or respond, and then act and speak in a calm, confident manner. The last thing you want to do is come across cocky. There's a difference between cocky and confident. I expect you guys to be confident in what you're doing, but not cocky to the point where you think you're so good that you miss something that's important and the patient dies because of a decision that you made. So with older patients, you want to identify yourself. You see how he's sitting on the stairs next to her, right? Imagine standing in front of her, towering over her while she's sitting on the stairs, right? Not going to work out too well. Okay, ma'am, do you mind if I assess you? And he grabs her hand, or he puts his hand out. If she puts his hand to her, then it's considered consent. She reached out, right? And now he's trying to calm her down, have a conversation with her. Now things will go along a lot better with that than it is standing above her, scaring the hell out of the elderly. Present yourself as a competent, confident, and caring provider. And do not assume that an older patient is senile or confused, because they may not be. They could be sharp as a tack. And you need to make sure you're not trying to pull something over them. You may encounter hostility, irritability, and some confusion. Do not assume that this is normal behavior, because there could be something else underlying. We'll go over all the different things that potentially could be during assessments. Approach an older patient slowly and calmly, and allow for plenty of time for the patient to respond to any question that you ask. Now, I'm not saying sit on scene for an hour, but give them the time that they need to give you the answers you're looking for. Watch for signs of confusion, anxiety, or impaired hearing or vision. And also, the patient should feel confident that you are in charge, that everything possible is being done for him or her. And be patient. Do not rush things. Now, if the patient is semi-conscious, let's get in there, get our assessment, and start transporting. But if they're alert and oriented, and you can have a communicating with the patient well, be patient, give them time to answer, don't push. If you push, they may give you the wrong answers and something could be missed. Older patients often do not feel much pain. Reason being is sometimes they've built up neuropathy and they can't feel pain in certain aspects. It's kind of like your diabetics, same thing. There's somebody that has having neuropathy and you won't be able to feel certain typical pains. For example, elderly female or females in general may not develop the same kind of cardiac chest pain, heart attack pain than males will. A lot of times you'll see mid back pain, upper back pain between the shoulders, or just upper epigastric pain, and they could be having a STEMI, a heart attack. So you don't know. So again, pains may be different. May not be fully aware of the important changes in their body systems. You must also be especially vigilant for objective changes as well. When possible, give patients time to pack a few personal items before leaving the hospital. If they feel comfortable having their Bible with them, I've seen that many times. They want to pack that to go to the hospital with, to make sure they're bringing their cell phone and charger, their glasses, their purse, wallets. Give them some time to pack what they need if they're not critical. If they're critical and they got to go, then they've got to go. Locate hearing aids, glasses, dentures before departure. A lot of these people want to have this stuff with them. And also, a lot of older patients are worried about the safety of their home, valuable items, and pets. I can't tell you how many times I've taken patients out and saying, be careful of the pets. Don't let my dogs out. And things like that. So you kind of just take the time to secure their home for them, make sure they have their keys, and things like that as well. Emergency situations are frightening for children. This is more for the children's side. Fear is the most obvious and severe in kids. They have no idea what's going on. You walk in with a uniform. They have a big ambulance to shut up lights and sirens, and sometimes there's a crowd of people gathered around them. So to get a child away from the crowds, away from all that noise and everything else, get them into a room with a parent or whatever, and have a conversation with them, get down to their level. Remember, kids toe-to-head assessment for kids. and that will make life a lot easier for them when you're getting your assessment, especially for communicating. Another thing as well is when you're communicating, keep things to their level of knowledge. Let a child keep a favorite toy, doll, or a security blanket. There's nothing wrong with that. If it's interfering with your assessment, then have it switch it to a different hand. Right? If possible, have family members or friends nearby, and if practical, let the parent or guardian hold the child during the evaluation. A lot of times they'll feel more comfortable. Even administering medications, if you're giving medications to a child, sometimes if you've drawn up the medication and you already have it, as long as it's not like intravenous or above your level. But if, let's say, you're doing something like liquid Tylenol or something like that for a fever, for example, a lot of times it's easier to have the parent give it versus you because they may be more apt to take it. Be honest with kids. Children can easily see through lies or deception. They are very good at that. So do not lie to them. If you do, they will hold you to it. Tell a child ahead of time if something will hurt. So, and sometimes I'll even do procedures on myself before doing it to them. What I mean is pulse oximetry. Doesn't hurt at all, non-invasive, but I'll put it on my finger first, say, look, see, it doesn't hurt. And then they'll let me put it on their big toe or I'll put it on their finger. A blood pressure cuff. I put it on my arm and then squeeze it up a little bit and let it go so they understand it doesn't hurt. Respect the child's modesty as well. Some children don't like being naked. So again, respect that. Speak in a professional, friendly way. Maintain eye contact and position yourself at the child's level. No different than what we talked about before when dealing with an elderly. Communicating with hearing impaired patients. So most have normal intelligence and are not embarrassed by their disability. Most of them will tell you, I can't hear, I wear hearing aids. So position yourself so the patient can see your lips. If they have hearing aids in, be careful they are not lost during an accident. They may be forgotten if the patient is confused, and ask family members about the use of hearing aids. Again, when you're doing assessments, if you're checking a temperature, make sure you notice the hearing aids are in there. They're not cheap. They're pretty expensive devices. So if you're checking a tympanic temperature, that's all you have. Pull the hearing aid out or have them take it out, check a temperature, and put it back in again. Understand that they are there. Some other steps to efficiently communicate with patients who are hard of hearing. Paper and pen available is amazing. Write down what you want to know. Some services have actually gone to that point where they've actually made some laminated questions with yes or no boxes, and they can hand them that, and they can check things off, yes, no, or whatever. That also helps a lot too. Never shout at them, and if a patient can read lips, face the patient and speak slowly and distinctly. Listen carefully. Ask short questions and give short answers. Learn some simple sign language, like sick, hurts, and help, as you can see here on the top. This is sick. I believe this one here is hurt. This one here is help here. Ask the patient if he or she can see it at all. Visually impaired patients are not necessarily completely blind. All right, they may just have a hard time seeing. Expect the patient to have normal intelligence. Do not treat them like anybody different, anybody else. Everything needs to be treated the same. Explain everything you do as while you are doing it. So if I'm taking a blood pressure, let them know I'm taking a blood pressure. If I'm putting a pulse ox on, cardiac monitor, and those are the big ones. Doing a 12 lead for your New Hampshire personnel here is remember that you're doing a 12 lead. You got to go underneath the left breast of a female, and it doesn't go on their stomach. Look at if they're big breasted, they actually have to lift the breast up to get underneath it. So keep that kind of stuff in mind. You're going to explain to them. I do have to lift your shirt up a little bit. We'll try to keep you as decent as possible. I'm going to put these stickers underneath your left breast, and then 2 on your sternum, around next to your sternum, and just kind of explain to what you're doing. Stay in physical contact with the patient as you begin your care. If the patient can walk to an ambulance, place his or her hand on your arm and walk them to the ambulance. Same thing with the elderly too, though. Sometimes they may just want someone to hold on to. So just put your arm out and have them walk with you. When you stand them up, turn and sit them into a stair chair or a stretcher from a bed. I usually tell them, hey, we're going to do some dancing. You know, it kind of makes them laugh a little bit. And, you know, and laughter is a great medicine, and it helps. We're going to transport mobility aids such as a cane with the patient to the hospital. Remember, they are going to be discharged at some point, so you kind of have to make sure they have their stuff to be able to get out. Guide dogs, easily identified by special harnesses. If possible, you can transport the dog with the patient in the back of the ambulance, as long as they are specific for that. They're dogs that can help out. Alleviates stress for both the patient and the dog. Otherwise, you can arrange for care of the dog another way. So here comes the big one, non-English speaking patients. So you have to find a way to obtain a medical history. Find out if some patients speak English. Some patients do speak English at times, but sometimes it's not very fluent for them. So use short, simple questions and point to parts of the body, or have a family member or friend interpret. Google Translate will be your friend, or Apple Translate now if you have an iPhone. To be able to get certain questions asked, you can do that and have it speak it in a certain language for you. Another thing too, if you have a high demographic area, let's say of Spanish people, you can print out pre-done cards with the yes or no boxes, but in Spanish. Or you can ask them certain questions. So there are other options that are out there versus you having to learn a different language. So know your demographic, then have cue cards with you to kind of help out with it. Consider learning some common phrases in other languages that are used in your area. So pocket cards, or use smartphone apps as well. Remember to request a translator at the hospital. Every hospital has the access to translators. So let them know there's going to be a language barrier up front on your radio report so they can get the iPads out and get the translators up and running. So there's not a delay in care. Communicating with other healthcare professionals, your reporting responsibilities do not end when you arrive at the hospital. You have to give an oral report to hospital staff members who has at least your level of training. So RN, paramedic, physician, things like that. You have to be able to pass off care. So you need to have your whole call down, memorized or on a piece of paper, and kind of read off to them what's going on. They're going to want to report from start to finish of what you did. So oral report components would be opening information. So this is Jane. She's complaining of chest pain. Pain's been going on now for about 2 hours. She states that her pain is in the center of her chest, radiating to the left arm with numbness and tingling. Feels more of a pressure. She's saying that she has about an 8 on 10 pain. We've given 324 aspirin. We've given 2 nitro with some pressure relief. Pressure after nitro is down to about a 3 on 10. Here's a picture of her. Here's a copy of her EKG. 12 lead was completed. We hand it over. She has the allergies. She's on these medications. She has this for a medical history. All this information is part of your oral report that you give to the hospital to be able to provide a better care for them as well. And they're going to be charting all this down in charts and or on a computer. They're typing it all out. So remember, if they're doing it on a computer and they're slow typers, just remember to say it slowly for them so that way they can write it all down or type it all in. Patient's response to treatments given, I already gave you that. Vital signs, they don't need to know every vital sign you took. What they need to know is probably the last set of vitals, or if you've noticed any decrease or increase in trending. So heart rate going up, blood pressure going down, and things like that. Sometimes there's certain information that's kind of private that you picked up on, but the patient, you don't want to say in front of the patient, so ask the nurse to step outside the room. You can have a conversation with them, mostly about psychiatric care, so that you don't wind up the patient again and get them all agitated. So when writing communication and documentation stuff comes into play, every time you get dispatched to a call, whether it's cancellation to a transport, a patient care report, PCR, needs to be generated and completed. This is also known as a pre-hospital care report, where it's a legal document that records all care from dispatch to hospital arrival. There are two types of PCRs. There's written and electronic. Maine, New Hampshire, Vermont, Massachusetts, the 4 states that I've worked in or hold licenses in currently, all use electronic run reports. We have a paper drop sheet that we leave at the hospital, but everything is done electronically. So before we get more into documentation, do you guys have any questions at all on what we've already discussed?
I'm good.
No.
No.
Perfect. So the PCR serves 6 functions. Continuity of care, legal documentation, education, administrative information, essential research records, and evaluation and continuous quality improvement. So the continuity of care is passing that run report off to the hospital so they can continue with care. Legal documentation, it's all there because of things that you did, you could be called to court for. Now, speaking on the administrative side of things, education-wise, me doing the clinical and CQI and education for accident ambulance, I look at every run report and I can take those and develop training programs. Or I can educate certain individuals on certain things. And that falls underneath the evaluation of continuous quality improvement, where every report is what they call CQI'd. It's essential research records. Obviously, it's very essential for that because it helps us develop new protocols. And the administrative information also helps with billing. Information collected on a PCR would be chief complaint, level of consciousness or mental status, vital signs, initial assessment, patient demographics. Also, demographics would be like your name, date of birth, address, things like that, insurance info. Administrative information gathered from PCR includes the time that the incident was reported, to the time the EMS unit was notified, to the time it was on scene, the time it left the scene, to arriving at the receiving facility, and the time that patient care was transferred. All these times are tracked and looked at. The goals for on-scene time are usually 20 minutes, and then you should be transporting in the back of the ambulance to the hospital. Anything more than 20 minutes usually requires a reason why you were there for a longer period, because of extrication, because of trying to get the patient in the house, because the patient didn't want to go initially, and things like that. So this is traditional written form, check boxes, narrative section, and whatnot, and then the computerized version as well. So elements of the narrative section, obviously time of events, assessment findings, emergency medical care provided, change in the patient after treatment, observation, final patient disposition, refusal of care will also be documented, and staff person who continued the care. Now I'm going to show you a narrative that's here in a few minutes. Include significant negative findings and important observations about the scene. Do not make any judgments about the patient's condition. Like earlier I mentioned about being drunk. You don't want to say that. Avoid radio codes and only use standard abbreviations. So 1048. I know in Maine that was an unattended death. Don't put down 1048, put down unattended death. Remember that the report itself is considered a confidential document. So I'm going to bring this down for a minute. Bring up some reports. So this right here was a let me a little bigger here. All right, can you guys see this okay? This one here was a simple report.
Yeah.
Obviously, there's an address and stuff that's in here currently. Again, this is for educational purposes. So 39-year-old, 86-kilogram male patient, seizures. Then I use what they call a chart form, which is chief complaint history, assessment, reassessment, and transport. So if you look down through all this, chief complaint was a seizure. This is more of a history. Obviously, the patient was alert and oriented. They were unresponsive with a GCS score of 9. Patient ended up having multiple seizures during transport, where I ended up giving 15 milligrams of Versed total to the patient to break the seizures, and a bunch of other medication. But you can kind of read down through this. You have an ALS assessment, vital signs. I put down vital signs Q5, IV is obtained, 20 gauge left AC, labs drawn, 12 lead acquired with a normal sinus rhythm, no ectopy, EKG transmitted to Memorial Hospital, Versed administered. And then you can see down on the transport here, you can say reassessment was done, patient more responsive after treatment. GCS score went up to a 14 versus a 9. It's still altered, but again, vomiting stopped after given Reglan, and then I also gave the seizures stopped after Versed. Patient was postictal. So this is kind of how it works. And it said report given to RN and placed in negative pressure room 8. And then I put down controlled substances. This is more of a 911 call. You can kind of see how that works there. If I did an interfacility transport, trying to find a. So this one here was interfacility transport that I did. So I used the chart form, which is down here, but I add extra stuff on top of it as well. So dispatch for a patient who had hyperkalemic, bradycardic. The transfer orders were listed down, along with giving like calcium chloride, Q1 hour, PRN for bradycardia. And I was told this patient here would probably code twice on me during the transport. Thank God he didn't. Then I go down as far as putting down like panels, labs, like CBC, CMP, all this kind of stuff for paramedic stuff. But I put down gases, ventilators, imaging, sending, receiving physicians, and it just breaks it right down. History, what happened to the patient over the time they were at the hospital. So you can see it's pretty in-depth reports. I've seen a lot of run reports in the past before that are like 3 or 4 liners. Those just don't cut it. They don't have all the information there to really describe what's going on with the patient. So if you put down, patient transported by 911 for seizures, this, whatever, and you didn't go detailed, what's going to happen in 4 years from now going to court? So
They're not going to remember.
I don't remember a darn thing at all. You're right. But if I put something like this, if you're reading all this here, my sample history, all right, 45-year-old male presents in emergency department. So he had missed 2 days of dialysis and became lethargic. Patient is bradycardic and the heart rate in the 30s, hypotensive, 69/35. Patient also presented with shortness of breath, dialysis patient. I listed right down the whole thing. This is a whole entire report from the ER of what happened. The RN told me all this stuff here. Patient has a central line triple lumen placed in the right femoral artery. And the thing is that all my information is here. So if I go to court 4 years down the road, I'll be like, hey, you know what? I kind of remember this call. This is everything they told me. I looked at all the labs. I know this guy's got a white count of 33.3. So right now he's got an infection somewhere. His H&H is a little low, so I know that he's got potential for a bleed. His hematocrit and hemoglobin are low. And I can look at all this stuff and say this patient was truly sick. This is paramedic talk, but just letting you know, to document all this as a BLS provider, not what you're seeing on the screen now, but all the information that was told to you, your full assessment, and everything else. It's going to help you remember stuff, and it's going to help document why you did what you did in the back of the ambulance. All right. If you have a patient that has acute coronary syndrome, the last thing that I want to see on a report is, well, we just gave nitro because protocol said so. Okay, but what was the experience for chest pain? Was the chest pain a pressure? Was it sharp? Was it dull? Was it radiating? Does it reproducible? Again, all those things help play a factor into your assessment. So if you get called to court and they say, Well, the patient had sharp chest pain, but they fell 20 feet off a ladder and landed on their chest. We're going to give them nitro because the protocol says chest pain gets nitro. You give nitro to someone who's bleeding internally, you've now killed them. You know what I mean? So again, you got to kind of look at all this as a whole, and kind of justify why you did certain treatments and what treatments you went with. All right. If you leave something out or record it incorrectly, do not try to cover it up. Okay. Paper reports, one line through, initial it. If you forgot something in an electronic report, you can always go back and add an addendum, but you cannot change your original report that's there. You have to do an addendum form for that. Falsification results in poor patient care and may result in suspension and/or legal action. If I gave medications to somebody and didn't document it, didn't tell the facility about it, and they gave those same medications, doubling up can actually kill somebody. So you want to make sure that all that information is documented. And if you forgot, call the hospital back and say, hey, I forgot to mention this to you right away. If your report's already done, fill an addendum out and then continue on. And we already covered that. So documenting refusal of care is a common source. This is a very common source of lawsuits. So thorough documentation is crucial. My opinion on refusal of care. It's harder to document a patient refusal than it is to document a transport. Being is you have to be way more thorough and more detailed on any kind of patient refusal because now we're signing them off and letting them stay home versus a transport. So you want to document all assessment findings, any assessment findings, emergency medical care given in the house. You're going to have the patient sign a refusal of care form. Have a family member, police officer, or bystander also witness and complete your PCR. When you're doing things like this here, you want to make sure that this patient is alert, oriented, person, place, time, and event. They have the capable decision-making capacity before they can sign any kind of refusal. Special reporting, we talked about this earlier. Gunshot wounds, dog bites, infectious diseases, suspected physical or sexual abuse, multiple casualty incidents, and things like that. Radio and telephone communications link you and your team with each other, with other members of the EMS, fire, and law enforcement communities. Right? We communicate well. Cell phones are phenomenal, especially when you're calling med control. You also have different apps you can put on your phone to help you through your calls if you have any questions of certain things like protocols, whatnot. Help the entire team work together more efficiently and effectively, and also provide important layers of safety and protection. Radios are going to be your lifeline. If you get stuck in a jam, you have your radio and you can call for help. Same thing with your cell phone. You can call for help. Base station radios. A base station contains a transmitter and a receiver in a fixed place. So it has two-way radio, consists of a transmitter and a receiver. So it can receive in your radio based on a frequency, and it can transmit based on a different frequency. And they're all done through like different PL codes that kind of separate stuff. And it goes to a repeater, which is usually at a tower somewhere, and then it transmits over to the next place or as a receiving radio station. Mobile radios and base radios have more power output, so you can get farther out with a mobile or base radio. Portable radios don't have as much power output, so you can't really get out as far when you're transmitting. So have you ever noticed people that are on fire departments when you're stuck in a valley somewhere and you're on your portable, like, we can't understand what you're saying. You get inside the ambulance or the fire truck and you start talking, they can hear you perfectly clear. It's a power output coming off the radio. So a mobile radio is installed in a vehicle. That's one that's in your fire truck, in your ambulances, in your police cruisers. Those are all mobile radios. They're used to communicate with dispatch, medical control, and ambulances often have more than one. So usually they have radios up front and they have radios in the back of the ambulance as well to communicate with the hospital for your radio patches. Portable radios are handheld devices essential at the scene of an MCI. They're helpful when away from the ambulance to communicate with dispatch, another unit, or med control. Again, not a lot of power output compared to a mobile radio, so you may not be able to reach certain areas you're trying to get to if it can't hit the repeaters. With that being said, you also have what they call direct channels, which means that it skips the repeater and goes radio to radio. They're good for more of on-scene stuff, talking like traffic control, inside the house, outside the house, and things like that. A lot of times you'll see those as your operational channels, which are more direct. So repeater-based systems, a repeater is a special base station radio which receives messages and signals on one frequency, automatically retransmits that on a second frequency that goes to a place receiving that, so like a dispatch center. It allows two mobile or portable units that cannot reach each other directly to communicating using a greater power of an antenna. So most of the time your repeaters will be sitting on top of higher mountains. As you can see here. So the ambulance is transmitting out, or go the other direction. So the dispatch center is over here on the left-hand side. They transmit out through their antenna. It goes to a repeating system, which is that tower in the middle, and then transmits that over to the ambulance so they can hear you, and then it goes back the other direction. So digital is something, I'm not going to say new, it's been around for a little while now, but digital signals are part of the EMS communications. So telemetry allows electronic signals to be converted into code and audible signals. We do not use telemetry, EKG, stuff like that in the back of the ambulance that's transmitted through signals like this, as far as like instant live feed. What we do have, though, is the ability to upload and transmit EKGs to hospitals via fax or via the internet. So most ambulances now have Wi-Fi devices in their ambulances built in, or they have Wi-Fi enabled monitors like the life packs do, or they're hooked into like iPads that have data plans on them. That way there they can transmit it. And part of where we work out in our valley is we have something called a STEMI bypass protocol, where we can transmit the EKG to the critical access hospital, get orders to administer heparin in the back of the ambulance, which is a fibrinolytic. It allows us, the hospital, to activate a cath lab directly for us, and we go right to the cath lab while we go into the ER. So those are systems that are developed based upon data transmission. Cell phones, EMTs often communicate with receiving facilities by cell phones. Up here and where we work, they like it all done by radio. The cell phone is used for medical control. Other communication equipment, ambulances often have an external public address system. So EMS systems may use a variety of two-way radio hardware. So simplex is a push-to-talk, release to listen, and a duplex is a simultaneous talk and listen, and a multiplex utilizes two or more frequencies. Med channels are reserved for EMS use. So there are med channels that are out here. New Hampshire has 4 of them that can be utilized. Maine's the same way, where they have, like, each hospital has the med channel set up, but a lot of them are all the same frequency. But because they're so far spaced apart from hospital to hospital, usually don't have much overlap in between. Other ones would be called a trunking system, which is the use of the latest technology to allow greater traffic. An interoperable communication system that allows all the agencies involved to share valuable information in real time. Mobile data terminals inside ambulances, what they call MDTs, receive data directly from dispatch centers and allow for expanded communication capabilities like maps. So some of the bigger systems actually have what they call MDTs in the ambulance. So dispatch can take that call without even going over the radio, and transmit that call to an MDT, which then alerts the crew when the ambulance is a call. They can sign en route, on scene, transmitting at the destination. All that can be done and input of hospitals where they're going to, all through an MDT. It also shows the dispatcher can see it real time as they're getting there. They can also track their vehicle and their vehicle location. It also shows maps and everything else that can be brought up. So the MDT stuff is actually pretty interesting technology. Radio communications follow the FCC guidelines, which regulates all radio operations in the United States. Allocate specific radio frequencies. Anytime your service has a radio, you have to have a license in order to be able to use that with call signs. Establishes licensing standards and operating specifications. This also establishes limitations for transmitter output and monitors radio operations as well. The FCC can monitor any radio frequency that's out there. Now, are they always listening to us? Probably not, but they have the ability to do so. And all radio transmissions, especially through dispatch, are all recorded. So responding to the scene, so the dispatcher receives and determines the relative importance of the 911 call, then assigns the appropriate EMS response unit that goes out. So they receive the call, they're EMDing it, they dispatch it out. The dispatcher then selects, dispatches, and directs the appropriate EMS unit, response unit to the scene, and coordinates with other public safety services. So it could be EMS, fire, PD, and whatnot. And then provides emergency medical instruction to the telephone caller. That's where emergency medical dispatching comes into play. And they have a series of cue cards or on the screen now, it used to be flip charts, that give the dispatcher information to give to the patient or the caller to start treating them. EMTs report any problems that took place during a run to the dispatcher, and EMTs also inform the dispatcher upon arrival at the scene. Communicating with medical control in hospitals. The principal reason for radio communications is to facilitate communication between you and medical control. Medical control lines at hospitals are supposed to be recorded by federal standards. So if you call med control around where we are, you call by phone, and that phone line is recorded. And so isn't the radio system as well. Medical control is different from state to state. So if you're in Maine, your medical control is going to be to the hospital you're transporting to. Same thing with New Hampshire. In Massachusetts, it's a whole different world. Your medical control is your medical control facility that you have designated already. So if I'm transporting to Boston City Hospital for Action Ambulance, I'm working down there, we have to call the Whidden Hospital for med control and speak with their physicians, even though we're going to a different hospital. So again, learn your state's protocols and what they are, whatever state you decide to go work in. Consulting with medical control service serves several purposes. 1, notifies the hospital of an incoming patient. 2, provides an opportunity to request advice or orders from medical control. And 3, advises the hospital of a special situation. So the way it works around where we are here is if you call med control, you still have to do a radio patch either way to let the nursing staff know you're coming in. Giving a patient report. Again, when you're giving a patient report, depending on what hospital you're going to, some require a full detail report and some require, let's say, a 38-year-old male complaining of right calf pain, vitals within normal limits, see in about 5 to 10 minutes. Then you're like, oh, okay, yep, let's go to room 6 on arrival. But there are other places that want a full report. 38-year-old male complaining of a laceration to the finger. We do have bleeding control. Vitals are as follows: blood pressure, heart rate, respiratory rate, pulse oximetry, temperature. Do they have their COVID vaccines? Things like that. They may go more in depth. So you need to understand what your hospital is looking for, and during your orientation or wherever you decide to work for, should have that information for you. Follow the established format and also include a brief history, a brief physical finding, a brief summary of the care given, and a brief description of the patient's response as well. Like I said, some hospitals want to know all this information and some don't even care. All they want to know is you're coming in with a patient and they'll prep for you when you get there. Medical control can be either offline indirect or online direct. So offline medical control will be your protocol books, and then your online medical control would be you calling in. So you may need to call medical control for permission to administer certain treatments, determine the transport destination of patients, and stop treatment and or non-transport of a patient itself. Does anybody have any questions so far?
Nope.
No.
Right.
I'm good.
So we'll take like a 15-minute break or so after we complete this chapter.
Thanks.
All right, so in most areas, medical control is provided by the physicians working at the receiving hospital. Obviously, many variations have developed across the country. So again, like every state's a little bit different. And the link to medical control is vital to maintain a high quality of care. Remember, these guys are physicians, okay? So give them a call. They have some good information for you. There are a number of ways to control access on the ambulance hospital. The dispatcher monitors and assigns appropriate clear medical channels or centralized medical emergency dispatch or resource coordination center. So in Maine and New Hampshire, you just call the hospital. In Massachusetts, they have something called CMED. They have Northeast CMED and Boston CMED. And you call a CMED channel, say, I want to report to BMC. All right? So they'll go to channel 22. So you switch to channel 22, then they page the hospital through a tone, then they come on board, and then you have communications. So again, every system is different depending on which state you go to. The physicians base his or her instructions on the information the EMT provides. Remember, they can't see the patient. They don't know the patient. So if you paint a picture for them, they're going to give you orders of what to do. Never use codes unless directed to do so by local protocol. None of the hospitals that I've ever been to, Maine or New Hampshire, requires specific codes on the radio. So just give them what they need to know. And then repeat orders back word for word and then receive confirmation. So if one of you were to call in to Med Control and say, I have a 55-year-old male complaining of chest pressure. Patient has prescribed nitro. Vitals are as follows. Give the vital signs and all that. Looking for orders to give up to 3 sublingual nitro as long as pressures stay above 120 systolic for blood pressure. The physician goes, I only want you to administer up to 2 nitro. So you repeat back, copy, administer up to 2 nitro as long as blood pressures remain this. All right. And then you get the physician's name. And then you're clear. Repeat back what they want. Do not blindly follow an order that does not make sense to you. Again, now, physicians do not know your protocols by any way, shape, or form, unless they're really involved in EMS. So you're calling in at the basic level, and they tell you to establish an IV. You're going to let them know that's not within your scope of practice. You cannot do that. Just because they say you can do it doesn't mean you can. Or if they tell you to give 5 nitro all at once, that doesn't make any sense to me. So you can actually question that as well.
So I have a question, Kevin.
Yeah.
When you call in, do you get someone every time, or do you have instances where everybody's busy and they don't pick up?
I have never had an opportunity in the 22 years. I've never been denied med control. I've had to wait on the phone for 5 to 7 minutes before. But again, if they're with a patient, unless it's something really critical, they can either bring the phone into the room so you can have a conversation with the doc in another room, or what will happen is that the ED tech or whatever, or nurse will say, med control, we need you out on the phone. They'll stop their assessment, come out, and then go back to the patient again. But remember, your smaller hospitals only have one physician, and you cannot get med control from a PA. It has to be an MD, a DO, a nurse practitioner, like that. They can give med control orders, but nurses and PAs cannot. You may initiate communication with hospitals to advise them of extraordinary calls or situations, like a hazmat response, rescue in progress, or multiple casualty incidents. Now, an MCI is a whole different world, because you're going to have, once you start breaking stuff down and assign your different sectors in an MCI, one of your sectors is going to be a transportation officer, and that transportation officer is going to notify hospitals and say, hey, how many people can you take? I need to know red, yellow, and green status. I can take 2 red, 5 green, and 3 yellow. Perfect. I know what you can handle. You're going to be calling all the different hospitals. That's more for your MCI. You got a rescue in progress, like a prolonged extrication or an entrapment somewhere, and things like that you might have to deal with. Let the hospital know ahead of time you're going to come in with a trauma, so they can start planning for it. Keep several points in mind, though, as well. The earlier the notification, the better. We'll talk about notifications here in a second. Provide an estimate number of patients and identify need for special resources. So one thing to kind of keep in mind with all this, hospitals want to know ahead of time about strokes, heart attacks, sepsis, traumas. Give them an alert. Around here in my area that I work in, if we have a stroke on scene, what we do is we call the hospital with a patient's name and date of birth with a stroke alert by phone. That way they can start pre-registration, and pre-registration will help get CT ready. So when you get to the hospital, basic level included, EMT level, you go right to CT. So they can do a scan really quick before they get teleneuro ready to go. Giving them heads up and this kind of information helps prepare certain aspects of treatments and care at the hospital. So those are several good points to understand. Like other EMS equipment, radio equipment must be serviced. Again, your radio is your lifeline, and things need to be serviced on a routine basis. So at the beginning of your shift, you want to check the radio equipment. Do a radio test. Radio equipment may fail during a run, so backup plans must be followed. It may include some standing orders. All right, so let's do some review. When healthcare providers force their cultural values onto their patient because they believe their values are better than they are displaying.
D.
D.
All right, D it is. So forcing your own culture values onto others because you believe your values are better is referred to as cultural imposition. All right, 2. When communicating with an older patient, you should do what?
A.
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 A it is. Number 3, when caring for a 5-year-old boy with respiratory distress, you should do what?
D.
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 D it is. When caring for a child, take special care to avoid upsetting them. Which of the following pieces of a patient information is of least pertinence when giving a verbal report to a nurse or physician at the hospital?
B.
D.
B.
B it is. However, family medical history is important, but not as important as the others. Kind of include to that. Patient has severe chest pain, possible heart attack at 40 years old, and their father and brother also passed away at 40 years old with heart attacks. That's good family information to know about. Oh, the answer is C for that one. All right. Well, that was the question, anyways. So, which of the following statements? Yeah. All right. So we know that's C. I went a little too far on that one. A device that receives a low frequency signal and then transmits it to relatively high frequency is called what?
A.
C.
C is the answer. The repeater receives messages from signals on one lower frequency and then automatically transmits them on a second higher frequency. So most of the radios we have in our ambulances, everything we use is all done through a repeater system. When treating a potentially hostile patient, you should try to diffuse the situation by
C.
C.
All right. C it is. Number 8. All the following functions of the emergency medical dispatcher are functions of them except
D.
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 D. D it is. After receiving an order from medical control over the radio, the EMT should do what?
D.
Yeah, D.
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 All right. Good. And last one. When requesting a medical direction for a patient who was involved in a major car accident, the EMT should avoid what?
A.
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 Mhm.
A it is. All right. So why don't we take, let's see what time is it now? Say 2:20. Let's come back at like 2:35. Get a little bit of a break, move around, stretch. At 2:35, we'll hit the last chapter. We should be done maybe before 5 o'clock.
Sounds good.
All right, so last chapter for the day. I'm going to cover lifting and moving patients. Again, a lot of this stuff here, though, we're going to do in a practical scenario. So some of the stuff we may skip over. Not skip over, we'll cover, just not in detail, I should say. That way there we can do it in a actual practical scenario. All right, so let's get through this here. So introduction. So in the course of a call, you will have to move patients to provide emergency medical care and transport. It happens. We're going to have to lift patients up. We're going to bring them up and down stairs. We're going to have to take them off the ground. We're going to have to move them on a stretcher. And there's all different techniques we're going to utilize and do the best we can without causing any injury using proper lifting techniques. So the wheeled ambulance stretcher, they come in all different types. They have Furnos, Strikers, power cots, manual cots, and all this different kind of stuff. Power load systems, power lift systems, and all these different ones that are out there. So wheeled ambulance stretcher, also called an ambulance stretcher or gurney, is the most commonly used device. So the wheeled ambulance stretcher weighs between 40 and 145 pounds, generally not taken up or down stairs or where the patient must be carried for any significant distance. We try our best to make sure that we don't use this kind of weight to carry up and down these stairs because obviously it's just too heavy. On top of that, add the patient weight. On top of that, it just makes things very uncomfortable and dangerous for us to be lifting up and down. So moving a patient by rolling using a stretcher or other wheel device is preferred when the situation allows to help prevent any injuries from carrying. Like I said, there's a number of models available. out there, from the power cots to the non-power cots to from striker to Furno. There's all different types. Before going on a call, before coming in on shift during orientation, you should be familiarized with specific features of the stretcher your ambulance carries. Most companies all have the same stretcher. Some companies that are not as fortunate funding-wise may have different makeshift stuff available to them. So just be familiar with what your service has, including stair chairs as well. Some general features, obviously there's a head end and there's a foot end. There's a strong metal frame to which all the parts are attached to it. It has a hinge at the center to allow for elevation for back and the back of head as well, so you can lift the head up, the head goes back down. There's also other devices that can even bend at the knees. Guardrails prevent the patient from rolling out. They have the metal guardrails. Some of the newer strikers have the hard plastic ones that they call wings now, so they can actually support a wider patient on there as well. So a lot of things have changed over the years. The undercarriage frame allows for adjustment to any height, so you can go up and down with it, whether it be electronic through hydraulic system or with a piston, or it can be done manually, the lifting and lowering. The patient is secured with straps to help protect the patient from further injury. So the newer stretchers that Furno are coming out with have different style of straps, but still it's all the same. There's one over the waist, there's one over the legs, there's one over the chest, and there's a shoulder harnesses that have to be utilized. Backboards are long, flat, and made of rigid rectangular material, mostly plastic. Uses to carry and immobilize patients with suspected spinal injury or other trauma. Backboards are used nowadays more for extrication than they are for spinal mobilization. As spinal mobilization is, I'm not going to say it's gone, but we're using it more on the stretcher itself than we are using on backboards. So commonly used for patients found lying down, used to move patients out of awkward places. Backboards, roughly 6 to 7 feet long, and holes serve as handles and as a place to secure straps. When we talk about securing patients to longboards, we'll get into more of that a little bit later as far as how we secure them during trauma scenarios. Moving and positioning the patient. So when we move the patient, we take care that the injury does not occur. So what we want to do is make sure we don't harm ourselves, we don't harm our team. We also don't want to harm the patient. So if we're moving a patient onto a board or positioning or moving them in the house, we want to cause the least amount of harm possible to be able to get the job done. Patient lifting and moving are technical skills that require repeated training and practice. Again, when you're doing your ride time, you learn how to use stretcher operations during that as well. Use proper body mechanics and maintain physical fitness greatly reduces the chance of an injury. And many EMTs are injured lifting and moving patients. That's where most of your injuries are going to come from in this field, is lifting some type of object or a patient, which is why we need to make sure we're lifting with our legs on our back and we're getting proper technique. So a little bit about some anatomy review of body mechanics. We have the spinal column, the shoulder girdle, the pelvis, and the legs. Kind of quick down and dirty review here. With that, these are the most areas of where we do the bending and moving and things like that. Lifting position, shoulder girdle should be aligned over the pelvis. Hands should be held close to the legs. This allows us not to bend over more, keeps us in line straight with our spine, and forces then goes essentially straight down the spinal column. Very little strain occurs with this, as long as we're doing proper lifting that way. So this is the correct way to lift, as you can see. So you can see everything's in line from the arms down to the legs. We're going to lift with our legs and our thigh muscles to lift up, keeping our shoulders intact. And this will allow for a better lift. Now, do you see where the handle is, where the guy's holding onto right there? That actually can move up or down on this stretcher here. So if you need to get a higher lift, you can always lower that part down a little bit. You can actually lift up a little bit higher. Or if you have to do a low push, you can actually elevate that back rack up at a higher position so you're not bending over. You may acquire a back injury if you lift while leaning forward or if you lift with your back straight but bent significantly over at the hips. So you want to have good body mechanics. This is not correct to lift at all. Right? You're going to blow a disc. You're going to put yourself out of commission. And for anybody that's had a back injury before, they're not fun. There's a lot of rehab. And a lot of times insurance, workers' comp will not cover it if you're doing improper lifting. Right? So you want to make sure you're lifting the right way to make sure everything is covered. And again, a significant enough back injury can put you out of work for life. That's the last thing you want to do is be laid up getting short-term or long-term disability, not be able to do anything with your life anymore. So lifting should be spread about 15 inches apart, shoulder width. Your legs should be. Place the feet so that the center of gravity is balanced. With your back held upright, bring your upper body down by bending the legs, and then grasp the patient or the stretcher. Lift the patient by rising your body, upper body, and arms and straightening your legs until standing. Keep the weight close to your body and keep your arms the same distance apart. That way there you won't have any significant movements that will actually cause you to tweak your back. The power grips get maximum force from the hand. So palms up, hands about 10 inches apart, all fingers at the same angle, and fully support the handle on a curved palm, as you can see here. When directly lifting the patient, tightly grip the patient in a place and manner that will assure you will not lose the grasp of the patient. If you're using your hands the other way, you have potential of it slipping out and then causing the patient to fall. Keep in mind that these patients are actually secured to these boards or scoop stretchers, in this case here, in this picture. So if they fall, they can't stop themselves. And if they twist and fall on their face, they can't put their hands out to stop them from landing on their face. The body drag, some principal rules, safe reaching and pulling. The same body mechanisms and principles apply to moving, lifting, and carrying a patient. So keep your back locked by tightening your abdominal muscles. Kneel down. Extend your arms no more than 15 to 20 inches in front of you, and alternate between pulling the patient by flexing your arms and repositioning yourself, as you can see in this picture here. So to drag a patient across the bed, you want to kneel on the bed to avoid reaching beyond the recommended distance. Drag the patient 15 to 20 inches. Complete the drag while standing at the side of the bed and use the sheet or blanket under the patient rather than dragging the patient on his or her clothing. It's okay to take a patient sheet to the hospital, but you got to do what you got to do. In the hospital, transfer the patient from stretcher to a bed with a body drag. I like to use it as a sheet drag over. So the stretcher should be at the same height or slightly higher than the bed. Use gravity to your advantage, as long as it doesn't cause any further harm. And your patient, you and your partner should kneel on the bed and drag in increments. So yes, we're asking you to get into the same bed as your patient to pull over. Now, if you're tall enough that you can reach across the bed and do a lift, that's perfectly fine. They also make other devices like hover mats. We carry those in all of our ambulances up here, where the hospitals have blowers. They can actually lift and they slide the patient over with hover mats if the patient needs one. So there's other devices out there that you can utilize to help you with this. For log rolling, you want to make sure that if you are log rolling somebody onto a stretcher, or onto a longboard, sorry, you want to make sure you're holding C-spine if it's suspected spinal, and the person at the head does the counting so you don't twist the spine and cause a fracture. So when you're log rolling, kneel as close as you can to the patient on the side. Keep your back straight and lean solely from the hips. So as you reach over, you want to put your hand on their shoulder and on their hip. Person at the head makes a count on 3, 1, 2, 3, roll, and you roll up towards your body. So you want to roll the patient front side into your knees by doing that. Whenever possible, use a device that can be rolled. I like using scoop stretchers now. They can be used as backboards also, and you don't even have to roll the patient at all. You just kind of go underneath them and scoop them up. They're a little more expensive than backboards, but again, every service is required to have a scoop stretcher on your ambulance. When a wheel device is not available, make sure that you understand and follow guidelines for carrying a patient on a stretcher. If you have to carry a patient, the best thing to utilize for that is having a 4-point, 1 point every side. If it's a big patient, then you want to go a 6-point, so 2 in the middle and 1 on head, 2 at the head, 2 at the feet. Would be your better option. The patient's weight, estimate the patient's weight before lifting. Often adults weigh 120 to 220 pounds. Where do they get that info? 2 EMTs should be able to safely lift this weight. It should be no problem lifting up to 220 pounds. Try to use 4 providers to lift when possible. Remember, it's more stability and requires less strength to lift. Now, the only thing you got to keep in mind when you're lifting with 4 people is look at height. You got someone who's 5'4" and someone who's 6'4" at the same side. Where do you think that patient's going to end up?
On the ground.
On the ground, exactly. So try to move things around based on height as well. That way everybody can kind of work together and make sure the patient's lifted appropriately. Do not attempt to lift a patient who weighs more than 250 pounds with fewer than 4 providers. Know the weight limitations of the equipment and how to handle patients who exceed the weight limitations. So, again, there is bariatric equipment that's out there and available. Know where you can get it from. In our area out here that we work in, we know that Conway Village Fire Department has the Carroll County cache of bariatric equipment. So if we need it, we can either go up and get it or they'll bring it to us. And then like Laconia has another set over there at their Weir station. So New Hampshire went out and put 2 sets in every county that's out there in New Hampshire. Main bariatric equipment might be Northeast Mobile Health Services. Some hospitals have the space services have them as well. So again, you have different services that have the bariatric setup, unless your service went out and bought them. And you should have a plan in place with dispatch on who they can contact. So lifting and carrying a patient on a backboard or stretcher, more of the patient's weight rests on the head and half than the foot half. So usually your stronger provider that's on the truck should really be picking up the head side. So the diamond carry you can do as well. So one-handed carry, use of 1 EMT at the head and the foot, and 1 on each side of the patient's torso. A lot of the stretchers nowadays also have handles that pull out from the sides as well to help with the lifting techniques. But if you're carrying a backboard, this is more the diamond technique that they're talking about. So 2 on the torso, 1 on the foot, 1 on the head. And you always want to make sure you're carrying like the front as you're walking forward, so that there's no tripping or falling. Lifting and carrying a patient on a backboard, use 4 providers, which we talked about. When rolling wheeled ambulance stretchers, make sure that it is fully elevated, is in the fully elevated position. So you want to make sure there's elevated and then there's load position. So the load position is all the way up, and you'll notice on a stretcher that it's kind of angled a little bit, so the foot end is down. You want to come down 1 notch and get out of the load position and get in the wheel position. Your partner should also control the head end and assist you by pushing with his or her arms held with the elbows bent. All right, so stair chairs. These are very, very good devices to be utilizing. Stryker, Furno, they all make different types, but they all have the chair itself, and some actually have the track system on it, which this one here has. The track system is a very good thing to use going downstairs. So use a stair chair to carry a conscious patient up and down flights of stairs. You can't use the wheels, the track system, the upstairs, but you can use them going down. Inside that track system, there's actually a self-braking system in it. So literally, not saying that you should do this in the field, but you can almost go down holding 2 fingers on the top and walk a patient down with these stair chairs, because that's how good the braking systems are. I'm saying this is not, don't do that. Use 2 hands securely on it. 2 at the top, 2 hands on the top and 1 person at the bottom holding both devices that come out for handles. You want to make sure that you use the cross strap technique on those, so over each shoulder and connect in, if you have the ability to do that with those. If not, then around the waist, around the chest, as you can see in the picture here. And then if they have a footrest, there's also a strap around the foot also. Moving the patient on stair chairs with a on stairs with a stretcher. A backboard should be used instead of for a patient who is unresponsive, who must be moved in a supine position, or who must be immobilized. Move a patient on the stairs with a stretcher. Carry the patient on the backboard down to the prepared stretcher. You want to make sure you place the strongest EMT at the head and foot ends, with a taller person at the foot end. Place both the backboard and the patient with the stretcher, secure both to the stretcher with additional straps. When you're going down a flight of stairs or you're going down a hill, do not make it so the head is down first. That will cause the patient to actually vomit, which is something that you don't want to do. Because then we really can't protect the airway. So loading a wheeled stretcher into an ambulance. You want to ensure the frame is held firmly between 2 hands so it does not tip. So as you can see here, as you're going into the patient, into the back of the stretcher, into the ambulance, you want to make sure that you're in the full load position, so it's all the way up with this stretcher. And I'll show you guys the difference during our practical sessions on that. Loading a wheeled stretcher. Newer models are self-loading, allowing you to push the stretcher into the ambulance that way. So those are the power load systems. Not all services have those, as they cost around $50,000 or so, or $40,000 to buy those. Other models need to be lowered and lifted to the height of the floor of the ambulance. So there are clamps in the ambulance that hold the stretcher in place. So there's all different types. There's a power load system that actually can lift and you slide it in. There's the regular load you have that hooks onto like a pin. And then there's also a track system now, which is required for all new ambulances at minimum. There's a track system in New Hampshire where it goes on a mid-track system with pins that slide in, and it makes it so that way there it secures better to the floor if your ambulance is ever to roll over. So there's all different types that are out there. As far as directions and commands go, the team actions must be coordinated. So you need to have someone that's in charge, a team leader, which indicates where each team member should be. Usually it's the highest license level on the call and or your senior provider. Rapidly describe the sequence of steps to perform lifting. Some preparatory commands are used. Example would be like all ready to stop to get the team's attention, or stop in a louder voice. Countdowns are also used. So we're lifting in 3, 3, 2, 1, lift. Things like that. Don't just say go ahead and lift. That'll throw people off, and then that's how people hurt their backs. Another thing to add to the stair chair part of it as well, when coming down the stairs, make sure the patient keeps their arms in. And if they have a hard time doing so, then strap their arms in that way. Because if they put their arms out and grab something, it's going to tweak your back and you're going to get hurt. Carefully plan ahead. If you have a patient in the house, have your partner go out and try to find the best means of egress. It may not always be the way you came in. Select the methods that will involve the least amount of lifting and carrying, and consider whether there is an option that will cause less strain. So if you're on the first floor and you can get a stretcher in the side of the house, the ramp through the garage, versus having to carry somebody out over 7 steps getting in on the front door, I would use the ramp to bring the stretcher into the house, where it's making things a lot easier. So again, search around the area and see the best way to get out. Emergency moves are where there's potential for danger, like fire, explosions, or hazmat. When you cannot properly assess the patient to provide immediate care because of the patient's location or position. So rapid extrication, and we'll cover some of that when we get to practical scenarios on how to do rapid removals. If you are alone, use the drag and pull method for the patient along the long axis of the body. This way here it keeps the spine more intact and straight. Use techniques to help prevent aggravation of the patient's spinal injury. Closed drags, blanket drags, arm drag, arm-to-arm drag, whatever it takes for those 4. Some emergency moves that you'll see here: the closed drag, the sheet drag, you can see under the arms, and then also the arm drag as well. We'll be able to practice these on one of our practical days. To remove an unconscious patient from a vehicle alone, move the patient's legs clear of the pedals, rotate the patient so the back is towards the open car door, and place your arms through the armpits and support the head against your body and drag the patient out, as you can see here. Urgent moves are necessary to move the patient with an altered level of consciousness or inadequate ventilation, if they're in shock or in extreme weather conditions. Some rapid extrication techniques require a team knowledge of knowledgeable EMTs. It doesn't have to be knowledgeable. They just have to understand how to get these patients out, and when to look at it. So when you're walking in, are they sick? Are they not sick? That's how we're going to determine that. Oop, too far. Rapid extrication techniques should be used only if urgency exists, so the patient can be moved within 1 minute. If this technique increases the risk of damage if the patient has a spinal injury, though. But again, are they going to be dead if they're left there, or are they going to have a spinal injury trying to get them out? So again, you need to make that determination if it's urgent or not. Look at all the options before using an urgent move. Non-urgent moves are used when both the scene and the patient are stable and carefully plan to get them out. So the team leader should plan the move using personnel, obstacles identified, equipment, or procedure and path. And you want to choose between whether or not it's a direct ground lift. So for patients with no suspected spinal injury, patients who need to be carried over some distance, or EMTs stand side by side and lift and carry the patient. Those are more of your non-urgent moves for the direct ground lifts. If you're doing an extremity lift for those patients who are no suspected spinal injury or in a supine or sitting position, this will help with the patient in a small space where one EMT is at the patient's head and the other is at the patient's feet. And we're going to coordinate the moves verbally. So again, we're going to cover all these things in a practical session. Transfer moves require direct carry. So move supine patients from bed to stretcher using a direct carry method or a draw sheet method. Most of the time, 99% of the time, we're using draw sheet. But there's also an availability of utilizing the scoop stretcher. All right, so geriatrics. Most patients transported by EMS are geriatric patients. That's mostly what we get called for. Skeletal changes may cause brittle bones, rigidity, spinal curvatures that present special challenges. allay the patient's fears with a sympathetic and compassionate approach. So we go to them, we make sure we're calm with them, we talk with them, let them know what we're going to be doing. Some of them may have shoulder problems, so lifting underneath the shoulders may be a problem as well. But we do have the ability of using straps and things like that to kind of lift them up off the ground. So we can use different webbing and things like that. We can make different harnesses or whatever is needed to get the patient up. As you can see, kyphosis and spondylosis. So you can see the kyphosis part where there's like a hunchback. Now, these can present a lot of problems. Imagine putting someone with kyphosis on a backboard. Is that going to be possible to do that?
No.
No.
No, not really. Unless we use significant amount of padding to help. So using pillows, blankets, and everything else to make it so it works. We can put them on boards, but again, like I said, you've got to pad them. And they may be in a lot more pain as well. So use your resources that you have. Bariatrics refers to management of obesity. 76 million U.S. adults are obese. 30 to 40% of adults are obese. Approximately 70% of children are obese, and back injuries account for the largest number of missed days at work. If you have a large patient, call for manpower, right? If we can't get them out. So stretchers and equipment are being produced with higher capacities now. So, for example, like the power load system itself, if I remember correctly, you can put it to 1,000 pounds, I think it is, 800 pounds, 1,000 pounds onto the power loads now to lift. It's unbelievable the amount of weight capacity stretchers they have now. But if you have some of the older ones, the most you can probably get is about 600-700 pounds of them. But again, they're not wide. So if you have a 5'6", 450-pound person, they're not that tall, but they're definitely wider. They're not going to be able to fit on our stretchers. So you're going to have to do some modifications and/or call for bariatric units to come for our transport. So again, if you already know this kind of stuff and your dispatch center has it all pre-planned, they can be starting a bariatric unit to your location to help you. As you can see here, this is the bariatric stretcher. These are not power cot assisted, but they have ramp and winch setups for ambulances for this. So those big bars you see on both foot and head end that stick up, those are designed to push and pull the patient lowered all the way to the ground. You come up behind an ambulance, these ramps come out, and they have a winch set up underneath the airway seat in the ambulance. It comes out, hooks in, and pulls the stretcher back into the ambulance. So that way there's absolutely no lifting whatsoever for bariatric people. Bariatric stretchers are rated to hold up to 850 to 900 pounds. They're also very wide, where a regular stretcher is rated for about 650 pounds. Pneumatic and electronic powered stretchers, as you can see here. These things make life a lot easier to load patients in. However, they are heavier stretchers as well. So you got to kind of keep that into consideration. Portable folding stretchers, we don't carry these on ambulances anymore, but there are also other abilities to get people in and out. They used to have stair chairs that converted into these many, many years ago. Some models have 2 wheels, like I mentioned before, and some can be folded in half. Used for difficult to reach areas, things like that. I like personally using scoop stretchers because there's no log rolling involved. You can kind of slide them underneath it. Other things you can utilize are flexible stretchers, as you can see in this picture here. But again, nothing that we're going to be doing as EMTs unless you're trained in high and low angle rescue. What you don't see on ambulances much anymore, in New Hampshire, they're not even required on the ambulances anymore, are the KEDs. They were used as the Kendrick immobilization device. really these things started in Indy cars and how to get the drivers out, but they kind of made their way into EMS, and they were utilized for stable patients, non-critical, and motor vehicle accidents where you think spinal immobilization needed to be held. That has since gone away, but they're still available to be utilized if needed. And some states still use them, but I know New Hampshire has taken it out of the protocols, and it is not a requirement anymore. Vacuum mattresses, which is what I talked about earlier, like the hover mats and whatnot, are alternative for backboards for mobilization for geriatrics and pediatrics to move. Actually, rephrase that. Vacuum is a little bit different. Air is removed from the device, allowing it to mold around the patient. I don't know if there's a picture. There isn't one there. Those are actually kind of neat. They're actually testing those out in California for a while, where basically it's kind of like a vacuum splint, but it's one big splint that kind of folds around the patient and keeps them still. Basket stretchers are another one. We'll be able to play with these a little bit as well. They're a rigid stretcher, but again, a lot of times patients will end up going onto a backboard first and into these. They're also called a Stokes basket or a Stokes litter. They can also be used in water rescue as well by putting flotation on these. Used for patient removal from remote locations, including water rescues and technical rescues. If a patient has a spinal injury, secure the patient to a backboard and place it inside the basket. If it's no spinal injury, then we can go a different route by just putting them into the basket alone. Please do not put the Stokes basket on a stretcher into the back of an ambulance. I've seen this happen multiple times, and it just takes up a lot of space, and the hospitals don't know what to do with them, so it becomes a big problem. So the patient has to come out of the basket into that, onto the stretcher itself. Scoop stretchers, which were really big in the early 2000s and kind of went away for a while, and all of a sudden they're back with a vengeance, and they're awesome. With this, you can go from sides. They can come apart from top and bottom. You can see a foot and head end. They're adjustable to height. Can you guys see the mouse on my screen when I do this?
Yes.
So where the mouse is located now, here and down here, there are adjustable pins that actually can make this longer or shorter. And then here and up here is where they come disconnected, so you can take them apart, go underneath the patient, and scoop them in. So again, we'll play around with some scoop stretchers as well. This splits into two or four pieces depending on the type of stretcher you're using, and they fit around the patient who's lying flat, and then they reconnect. A neonatal isolette is sometimes also called an incubator. You will never run into those in the field unless you're working on a neonatal pediatric truck. They cannot be transported on wheeled stretchers, and our ambulances are not designed for isolette transport unless you have a specialized ambulance. So for those of you in Maine, the Barbara Bush trucks that Northeast runs, those have the isolette connections inside. And there's a lot more than just connecting inside of it too. These things have oxygen and medical air attached to them. They're secured inside the isolette, and they have the ability to be patient to be worked on through holes in the side where the hands can go in. They can actually do certain procedures. So my battery's getting a little low. We should be able to make it. All right. All right, so proper position. Decontamination, that's what I was on. So decontaminate equipment after all use for your safety, for the patient's safety, for the crew's safety, and to prevent the spread of disease. Take the ChloraPrep stuff, wipe stuff down. You're cleaning the rags and whatnot, and clean everything up. Make sure it's ready to go for the next patient. So patient positioning, proper position the patient depends on the chief complaint. So patients with head, neck, or shock, spinal injuries, pregnancies, obese patients need special lifting and moving techniques. A patient reporting chest pain or respiratory distress should be placed in a position of comfort. Typically, they're going to sitting, Fowler position, or like half resting back, which is called semi-Fowler position. And patients in shock should always be placed supine, lying flat. That way there, it doesn't take as much for the patient's body to perform and be able to pump through. We'll get more into that in shock treatment later on. Patients in late stages of pregnancy should be positioned and transported on their left side. Excuse me. The unresponsive patient should, with no suspected spinal injury, should be placed in the recovery position, which is on the side as well. A patient who is nauseated or vomiting should be transported in position of comfort. Please do not, if they're vomiting, lie them down flat, because if they aspirate into the airway, you got a bigger problem ahead of you. As other patients, obese patients should be positioned the same as other patients with similar conditions. You got to remember positional asphyxia with these patients. You don't want to make sure that you lay them down flat, because it can actually make them so they can't breathe anymore. Evaluate for correctable causes of combativeness as well for medical restraints, head injury, hypoxia, hypoglycemia. Follow your local protocols with restraints. Restraints require 5 personnel. Restrain the patient if in a supine position, and positional asphyxia may develop in the prone position. So you want to make sure you leave them supine, not prone face down, as you can see here. So remember I mentioned before, one hand above, one hand below? That's what he's trying to do here. This way here, your patient can't sit up at all, and it actually makes things a little bit easier to take care of the patient. So apply restraints to each extremity, assess ABCs, mental status, distal circulation after restraints are applied, and document everything that you do. So personal consideration. Question to be asked before moving a patient: am I physically strong enough to lift or move this? And it is okay to say you're not strong enough. Call for help. Is there adequate room to get the proper stance to lift the patient? If not, do we need to slide them to get to that point? Do I need additional personnel for lifting assistance? Remember, an injured EMT cannot help anybody. So make sure you get the right manpower in. All right, so in review, what is the first rule of lifting?
B.
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 All right, D it is. All right, so number 2. When lifting a stretcher using a power lift, you should
B.
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 D.
let's go with C. When lifting a heavy object, your hands should be facing palms up. This provides a better lifting power and is also not as stressful on the wrists. Right. It is impractical to apply a vest-type extrication device on a critically injured patient to remove him or her from a wrecked vehicle because it will do what? Or it will.
A.
Hearing a lot of A's.
B.
A.
D.
Because if you have a critical patient, you need to get them out. A type of device like a TED, it takes too long to apply, which will then be detrimental more towards the patient if they're critical. Number 4, proper guidelines for correct reaching include all the following except
D.
D.
all right. And the answer is D. Number 5, an injured hang glider is trapped at the top of a large mountain and must be evacuated to the ground. The terrain is very rough and uneven. Which of the following devices would be the safest and
B.
most appropriate?
B.
B.
A
B.
lot of B's.
B.
And B it is. When two EMTs are lifting a patient on a longboard, they should do what?
D.
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 D, excuse me.
It is. Number 7. This is considered to be an emergency move.
D.
D.
B, the firefighter,
D.
because it's a one-person technique that is used when a patient must be removed for a life-threatening situation. So an emergency move would be like the firefighter drag. Number 8, to extract the patient from the basement of a building, you must transport the patient up a flight of stairs. In doing this, you must ensure that
A.
A.
A it is. Two more to go. If an injured patient needs to be removed but is not in immediate danger from fire or building collapse, you should do what first?
B. D.
D.
A.
All right, a bunch of different answers. Let's see what we got. The answer is B. The only time your attention should be directed away from the primary assessment of the patient is when the patient's life or your life is in immediate danger. Number 10, the rapid extrication technique is a
D.
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 excellent. B it is. All right, let me close this down really quick here. And bring up this. All right, so Wednesday the 15th, we're going to be covering medical terminology in the human body. Whatever we do not cover this day, we will touch on the 19th. On the 19th will be a practical day for practical assessments, which means we'll be doing in-class lecture that day. They'll be held at the Tamworth location. If anything changes with that location, I will let you know. And if it does change, I'll be in the area at a different fire station depending on what else is going on in the building that day. Again, it won't be any significant drive. Actually, it might be a little bit closer for most if it does get moved.
What did you say? What did you say about Wednesday's class?
So
I-
Wednesday's class will be starting at 6 p.m. We're going to cover medical terminology first and then the human body.
Right.
If for some reason we run till 10 o'clock and there's still more to go, we can just reconvene on Sunday. But I am fairly certain we'll be able to get all that in. It should be no problem to get in with 4 hours. And then
What's going to be the time frame for Sunday's class?
for Sunday,
Yeah.
so we'll start at 9 o'clock in the morning, and we got to go through 2 chapters, and we're going to do practical sessions on airway management. So we're going to have airway heads, and we got to go through airway practice.
Okay. I just have to work. I have to be back in Maine and get ready by 3 in the afternoon.
So the other option is doing a short Sunday, and it's up to you guys because it's your class, is doing a short Sunday, just doing it virtual. Then on October 3rd, it's 8 hours of practical sessions. We can do all that through the 8 hours of practical sessions on October 3rd.
I would be willing to do that on October 3rd.
Would that be easier for everybody else? Is to just do virtual on Sunday for 2 chapters and be done like around noontime, 1 o'clock?
Yeah.
All right, we'll do that then. That's perfectly fine. And then we can just hammer out all the practical sessions on October 3rd. And we'll, like I said, we'll have airway stations set up. We'll have multiple airway heads. all the different training stuff that we're going to need. We're also going to do trach maintenance and blind insertion airway that day as well.
Okay.
So quizzes don't change. So I opened up
Right.
the quiz that was due today, since some people hadn't gotten it done yet, and maybe there might be some confusion. I opened it up till tomorrow morning at 9 a.m. So the quiz that you guys just took for chapter 1 is open till tomorrow morning. The quiz for today for these 4 chapters opens at 5 p.m. and closes at 6 p.m. on Wednesday.
Okay.
Also,
Is that
don't forget you need to
or is
do
that 4
ebook quizzes. What was that?
Is that one quiz for the 4, or is that 4 separate quizzes
So,
for each chapter?
So the quiz that I made is 1 quiz for all 4 chapters.
Okay.
And then you have the ebook quizzes that have to be completed as well.
Yeah.
All right. Any other questions at all? Right. And the first 2 chapters we covered today are already on YouTube to watch on that, and the other 2 should be up shortly. So we should be good. Any other questions? Feel free to reach out to me via email or by phone. I'll be able to help you out.
Okay, thank you.
Thank you.
All right. Have a good night.
You too.
Have a good one.
You too.